let's invite both speakers for the Q&A session. I invite all of you. I'm sure that you have kept all the burning questions to the end. If anyone has any question, tak ada physical, any? Semua juga. Oh, okay. Everyone. Okay. So I don't see many questions here. Okay. So because I'm the chair man of this, so I got the advantage to ask my own question first. So I think Dr. Iskandar has shown that a lot of evidence of RA in ERAS, but what is your opinion in the take-up by the surgeon employing? I know we can offer a lot of, contribution to the ERAS, but I think in real life, what do you think is the take-up by the surgeon for the ERAS surgery?
Thank you, Dr. Ami. So at the end of the day, I think all of you can agree, when you want to convince a surgeon, you need to explain to him how he or she is going to benefit from this. You know, if they don't benefit from whatever intervention you do, they're not going to want to support your intervention. So the good thing about ERAS is it was initiated by surgeons, and all ERAS pathways will involve an anesthesiologist, surgeons, anesthesiologists, physiotherapists, pharmacists, and so on. So you don't need much convincing because you have guidelines already. You know, there's a lot of guidelines out there where a block is a grade A recommendation. So what I see in my practice is this is slowly changing. For example, when I first came back when I was leaving UKM as a master's student, surgeons still did not allow adductor canal blocks, for example. They were thinking the block is so close to their knee, confirm infected, you know. But now they're allowing it. Okay, they also allow catheters. You know, if I talk to them, because they can see the benefits. They can see that when you do this compared to an epidural analgesia, patients benefit. So we are adopting more and more guidelines, protocols. We have hepatobiliary protocols for ERAS and so on. So I feel that this is a way forward. It's something which everyone will be on board. I don't think you're going to have much resistance when everyone can see the benefit from it.
Okay, I think these questions for Dr. Ng Zitek. Okay, what is your technique of choice for TKR? Are you giving GA plus adductor canal block for most of your TKR surgery?
Thank you for the questions. In my practice in HKL, it depends. We will discuss with the surgeon and depends on the case. If it's a non-complicated primary TKR, we can perform it under spinal, combined with the adductor canal block, and also surgeon will give the local infiltrative analgesia. Yes. So yeah, but if we discuss with the surgeon, if it's a complicated surgery, they need more time, then we will conduct it under general anesthesia and provide the adductor canal block. Yeah, thank you.
Is there any role of using Ipeg on top of your adductor canal block?
Well, if you ask me my personal opinion, if the surgeon is giving a local infiltrative analgesia, they target the posterior capsule, which is the same target as the Ipeg. If this is my personal opinion, I feel that if the surgeon are giving LIA, I don't think it's necessary to give an Ipeg. Yeah, I do have feedback also from one of the surgeons. This is just a comment by the surgeon that the Ipeg is also very near the knee joint. So because where we inject the Ipeg is actually very close to the knee joint. So there is a concern by the surgeons that we are going too near to their field. Yeah.
Okay. The ERA Society does not recommend RA for laparoscopic surgery. Okay, what about if laparoscopic and KIV open and we still need to give opioid sparing analgesia and it's due to strong patient factors? Do you recommend blocks preoperatively?
Pre-operative block for a laparoscopic KIV open. Usually I don't do. I mean, it depends on the surgeon. You need to know your surgeon well. What is their conversion rate to open? So, you know, if there's someone who's going to convert almost all the time, maybe. But so far, I've not had this experience. So usually the most important thing is you counsel the patient, you give them the options. You tell them, if the operation is converted open, we're going to do the block before we wake you up, before we extubate. We can do it in the recovery for you. So no, in summary, I won't do the block if it's a KIV open.
Another thing, the rectus sheath block is not mentioned in ERAS for abdominal surgery. Can you give comment about this block?
So that's a good question because rectus sheath block has been around longer than many of the newer blocks. So the problem with rectus sheath block is it provides mostly somatic, or not mostly, provides purely somatic analgesia. Another thing, that is one reason it's not been picked up very well in studies. The second thing is the proximity of the block to the typical incision. So surgeons are not very supportive of the block. So because of that, when the ERAS Society comes up with the guidelines, they don't really look at it. They prefer like a rectus sheath. A tap block can perform the same thing a rectus sheath can. So that's why the support for rectus sheath is not really there. So I don't foresee this changing in the future. Rectus sheath is probably not going to be a strong recommendation in any situation, but it's still a useful block. So I perform it often, especially when you have like emergency cases, laparotomies, middle of the night, and elderly, you want to extubate them, you have good analgesia. It's still something I do, but I don't foresee it becoming part of guidelines, prospect guidelines, or ERAS Society guidelines.
Okay. Yeah, I think you mentioned about prilocaine in your lecture. The audience asking whether it's already available. Are you using it routinely now?
That's a good question. Anyone from BBRON want to come out and say anything? So it's not in our blue book, but it's available in Malaysia. You can order it directly. I have used it for private patients because they can purchase directly. And I've used it for urological procedures, mostly urological procedures. So because patient can go home like a few hours after surgery. It's of course a bit more expensive, not a bit, it's of course more expensive than having Marcaine, but the benefits are clear to see. So it's something you want to consider in certain cases. So yeah, in summary, no, it's not available in a blue book, but you can purchase it directly from the company.
Okay, Dr. Shah has a question.
Assalamualaikum and very good morning. Thank you very much for both the speakers for excellent lectures. Maybe not so much questions, but probably some thoughts to be shared. I think when it comes to, when you talk about ERAS, even regional anesthesia, even if it's not on, as part of the ERAS, I think it's all about your cooperation with the surgeons, your ability to work with the surgeons. Just to highlight an example, I know Dr. Ng was talking about ECB. Well, I think currently I have a surgeon in Gleneagles Medini who he discharges the TKR the next day. And he just wants me to do a adductor canal block. I think it's also the fact that his technique may be less traumatic, somehow or other they're not too painful and they're up and about. And if they're doing it, if he does it in the morning, the patients are already standing up in the afternoon. And we are kind of planning to possibly do daycare surgery as well. But I think coming back to the ACB, I think there's a bit more. There are now permutations of the original description because now there's a high volume proximal adductor canal, there's a dual substotal thing. I think personally looking at what I've done, because when I block, I usually scan up and down afterwards and see. But I think the ones that will definitely have good pain relief is when there is actually spread proximally. And you kind of, where, but somehow or other, I think there's data to suggest it, that even it's spread and somehow blocks the femoral nerve, where we do the femoral nerve, the degree of motor blockade may not be that as often. And also, if we are looking to block the sciatic, for example, because sometimes they do complain of posterior pain, then the high volume will kind of encourage it to go down and in between the interfacial plane. So I think that's my thought. I don't know whether you have any thoughts. A few things so that I don't have to hog on to the mic. For example, I know Iskandar was talking about thoracic paravertebral and how it's not. But I think to encourage, personally, because when I'm now doing a bit of VATS and I do put the continuous thoracic paravertebrals catheters, I find that to encourage, there are certain blocks that some gadgets may actually enhance, I would say, the uptake or encourage the use. Particularly, I find the needle guide is very helpful because there are certain blocks, for example, the PAX block when you have a slightly bigger breast, will help you keep the needle in that plane that you want the needle to go through. Because sometimes, when you have this sort of not so flat surface, it's quite difficult to actually make sure that you are holding your needle goes through the plane where you want the needle to go through. But I find that the needle guide is really helpful. Just probably comments from Iskandar. When I was in Singapore, the surgeons were very adamant that they don't want PAX block because the thing it disrupts their plane, particularly when you're using axillary gradients. And when I shifted to Medini, the surgeons were so happy and insisted everybody. So every major breast surgery gets PAX block because they say that it causes a bit of edema and they know where the axilla is, and they're happy that it sort of creates that barrier. Oh, now we're in axilla. And I know that Prospect and ERAS does not mention much, but I think there was one 2019 RCT where they were looking at basically PAX and the basically ERAS and regional anesthesia as part of the protocol. They found that, of course, better pain control and things like that. Another point is, I think LSCS, I think there's a 2016 IJOA meta-analysis and found out that actually IT morphine is still better than TAP at that particular point. But that's why I haven't changed my practice when it comes to LSCS. Thank you very much.
Thank you, Dr. Shah, for sharing his experience. Do we still have time for questions? I think if there's one last question, since I'm the chairman. So I have a patient. Let's say I have a patient who's already received LIA, and I've given adductor canal block. Now he's in severe pain in recovery. So what do you do?
Well, if patient has already received adductor canal block and LIA, and actually I think the next step is to rescue opioids already. If it were me, I would go for rescue opioid because I won't consider another rescue block because of in the fear of the local anesthetic systemic toxicity. Yeah. I would optimize the multimodal analgesia and also use rescue opioid. Yeah.
Okay, so I think that will conclude our session. Thank you to Dr. Teck and Dr. Iskandar for excellent presentations. Let's thanks both of them the usual manner. Okay.